Hey guys, we're going to be talking about the Glasgow coma scale. I'm going to be talking about the eye-opening response in terms of the Glasgow coma scale. So if I've walked into the room and I've seen Maddie and her eyes are already open, then straight away she gets a 4. We know that she's conscious, alert, and I guess we'll find out if she's orientated. But if I was to need to call out Maddie's name to get her to respond, so I'd say, Maddie, are you awake? She would open her eyes. I'd have to determine whether she was just simply asleep or it was my voice that prompted her to open her eyes. If there was no response at that stage, then I'd probably introduce some painful stimuli to get her to respond. So I would press down on her fingernail, and there we go. We now have a response, so she'd score a 2 on that stage. But the worst case scenario is we get no response from Maddie at all, so then she'd score a 1, and we'd continue on with the Glasgow coma scale.
Continuing on with the Glasgow coma scale is the best verbal response, which ranges from a scale of 1 to 5. Patient receive a 5 if they're completely alert, orientated to person, time and place. Can you please tell me your name?
Kat.
And can you tell me what day it is?
It's Wednesday.
And do you know where you are?
Hospital.
Very good. A patient receive a 4 if they're confused or disorientated when answering but their speech is coherent. Kat, can you tell me what year it is?
1992.
Okay. A patient receive a 3 if they produce inappropriate words or jumbled phrases, often completely unrelated to the question being asked. Kat, can you please tell me where you are?
Christmas.
Just lie down for a minute. A patient receive a 2 if they produce incomprehensible sounds or words. And finally, a patient receive a 1 if they have no response even with painful stimulus. That is the second Glasgow coma scale best verbal response.
When assessing the motor response, it is scored on a scale out of 6. A patient will score a 6 if they can fully obey a command, such as, Mel, can you wiggle your fingers for me? A patient will score a 5 if they can localise the pain. When I apply pressure on the supraorbital notch, the patient will attempt to swat the pain away. A patient will score a 4 if they withdraw or produce flexion from the painful stimuli. If I apply pressure just below the nail bed, the patient will attempt to move their hand away from the pain. A patient will score a 3 if they produce what is called abnormal flexion or decordate posturing. The hands are turned inwards towards the chest, legs are extended, generally rotated and plantar flexed. A patient will score a 2 if they are producing an abnormal extension or decerebrate posturing. The arms will be extended and will be close to the body and rigidly straightened, with fists rotated into the body, legs are straightened with feet pointing downward. The patient will score a 1 if they produce no response. So when I apply pressure to the nail bed, Mel doesn't give a response.
Taking a pupil assessment, the nurse is assessing for 3 things: the pupil shape, the pupil size and the pupil reaction. With pupil size, it is measured against the pupil scale on the neurological chart and compare for comparison with each eye. The normal range of size is between 2 to 6 millimetres. While also doing that, you can look at the pupil shape. Normally it is round, regular and equally both eye. However, be mindful that 5% of people are normally unequal. Record as round or draw to indicate abnormality on the chart. With pupil response, a bright light is shone from the outside to the middle of each eye, one after the other, to measure pupil response. To obtain a more accurate result, it might be necessary to dim the lights. The light should induce pupil constriction and dilate with the withdrawal of light. A positive reaction is marked with a plus. A sluggish reaction is recorded as an S. And no reaction is hyphen. And if the eye is closed due to swelling or bruising, then it's marked as a C. Limb assessment is undertaken to assess inequality or weakness. Each extremity is tested unless there is a physical injury or other problem with the limb. Ask the patient to do a series of movements with each limb and compare the opposite sides. Should be given clear instructions and only contain one command. So Rick, can you please grasp my hands? Yep. Ask the patient to put a wrist on their chest while you provide resistance to test arm strength. And you would do it with the other arm as well. To assess movement against gravity, ask the patient to raise their arms and legs one at a time. Ask them to do it again. Now only apply downward pressure on either their forearm or lower shin, again to test for strength. So, Rick, can you lift up your right arm for me? And your left arm? And you would do it with your legs as well. Now I'm going to apply downward pressure to each limb. So, and compare with each side. So, Rick, could you lift your arms up for me? Yep, and I would do it with the legs as well. To assess their feet, ask the patient to plantarflex and dorsiflex their feet, again with and without resistance to assess their feet. So Rick, could you please point your feet out for me? Yep, and point them back. Now I'm going to apply pressure, so point your feet again, and this time, yep, pull back, good, and other way, very good. So with mild weakness, what would happen is the patient would, when you lifted the leg up, it would fall down very slowly, but with severe weakness, if they were to lift the leg, they may not able to, or they would just drop it down. However, this limb assessment is very subjective, and therefore another nurse should be there with you and do it as well. Changes in motor strength, especially between right and left sides, may indicate imminent neurological failure and should be reported immediately. Now I'm going to demonstrate the documentation of the neurological observations on the adult neurological observation chart. So firstly the patient identification goes there, and you write the date here with the time. This region here is where the GCS is marked. So for example, if the eye's open to speech, you would put a dot in the 3, and you'd mark them as a 3. Best verbal response, if they were orientated, then they get a 5, and you just put a dot in there. And best motor response, if they were obeying command, then you'd put a dot there. Usually you record the best arm response in that section. Here's where you've got the pupil scale. So when you're looking at their pupils for their size, you mark down here where it says pupils. You've got the right and left side, and you just say the size. So you just go like, if it was 2 millimetres, you would put 2 in there. For the reaction, you can either put a plus for react, S for sluggish, a hyphen for no response, or a C for eyes closed, and you do that for each eye. And here we have where the limb assessment is. So we've got arms in this section and the legs in here. Record right and left leg separately if there is a difference between the sides. So say if we had a left weakness, we'd put an L there, and if we had right mild weakness, you'd put a right there. Use a dot if equals. So say if we had legs severe weakness, we'd put a dot in there. Here we write in the vital signs, so it's where the blood pressure, the pulse rate, the respirations and the temperature goes, and it shows on the chart what pen to use or how to mark it in there.
One of the components of the scale is the verbal response, which cannot be assessed when children are very young. A modified version of the scale, the paediatric coma score, was created for children too young to talk. Using the paediatric Glasgow coma scale for children under 2 years of age was compared favourably to using the standard GCS for older kids. It was especially accurate for babies and toddlers who needed acute intervention. When applying the GCS, the final score is determined by adding the values of E, eye opening, verbal response and motor response. This number helps medical practitioners categorise the possible levels of survival, with the lower number indicating a more severe injury and a poorer prognosis.
Vital signs are monitored in 15-minute intervals to assess the intracranial status and cerebral perfusion pressure of patients. Slowing heart rate, decreasing pulse rate and decreasing blood pressure, as well as widening pulse pressure, indicate signs of increased intracranial pressure. In addition to increased intracranial pressure and reduced cerebral perfusion pressure, rapid respirations, increased systolic pressure and elevation of temperature can indicate increased compression of the brain. Oxygen saturation levels indicate how much oxygen is being perfused around the body, and therefore reduced oxygen levels can indicate reduced cerebral perfusion pressure and increased intracranial pressure. As a result of vital sign changes and therefore increased intracranial pressure, there is then a significantly reduced cerebral blood flow, resulting in ischemia and cell damage in the brain.
It is essential for the nurse to assess a patient's baseline neurological status. This will help indicate any changes. If there is a fall in a patient's GCS of more than 2, the nurse must document the findings and immediately inform the doctor. Some of the things the nurse can do to assist the patient if their GCS is dropping is to reposition the patient, maintain a patent airway, apply oxygen and ensure ventilation is adequate, and assist if not.
My portion of the reflection is, as a group we thought we could have demonstrated GCS in a better clinical setting and in a more professional manner. By doing this, it would have given the viewers a deeper insight in assessing and documenting GCS.
My portion of the reflection will be on time management. It was difficult to manage my time as part of a group member, only because I live in Geelong and the distance I needed to travel. It's a credit to the other members of the Fabulous Four for being so flexible and accommodating to help me and to help our group. In terms of time management for the GCS, it's a relatively simple task and is designed to obtain results quickly. And that's important because it's going to help produce a positive result for the patient.
Met up as a group, we probably could have been a bit more organised and prepared. What was good about this group was that if one member was struggling, the others were there to provide support and give assistance.
Overall, all group members cooperated well together and there was equal contribution. Each person was allocated 2 tasks and researched and presented their own topic.